very rainy day and Friday in Cincinnati today. But I'm really happy to be here today on the Ms.Medicine Facebook Live with my good friend and colleague, Dr. Eileen West, who's in the DC, Northern Virginia area. We're going to talk about osteoporosis today. But before we get into that, I wanted to say a couple things about Ms.Medicine and the network that Ms.Medicine is building, and how wonderful Dr. West is. I talked briefly about COVID here locally. We'll hear a little bit about what's going on with COVID in the Virginia, Washington, D.C. area, and then we'll talk about osteoporosis, which I'm so excited to have Dr. West here. So first of all, so Ms.Medicine. So what is Ms.Medicine? So this is an organization that is committed to advancing gender-specific women's health care, largely gender-specific women's primary care. And the vision of Ms.Medicine is to build a network of specialty-trained women's health primary care providers across the U.S. in a couple different models. One of them is a direct primary care membership model. And we're also working on developing a provider alliance with a much larger group of women's primary care providers with the goal to elevate the standard of care of women's gender-specific primary care. I am thrilled to have Dr. Eileen West as one of my esteemed friends and colleagues, who is our Ms.Medicine provider in the Washington, D.C. area. And Dr. West brings a host of experiences and great training to our Women's Health Network. One of her big areas of expertise is osteoporosis, and that's what she's going to talk about today. And we'll get to you, Dr. West. Briefly, so COVID, obviously numbers across the globe and in the United States are continuing to go up. Varying states now are releasing stay-at-home restrictions. Ohio's on a pretty good aggressive timeline now to open. We are starting to open our restaurants on May 15th, hair salons and nail salons on May 15th, and kind of expanding over the rest of the month. I will tell you personally, I have concerns about the rate at which we're going. I understand the reason that we're going. I'm desperate to have relaxed social distancing as well. But from what we know, the prevalence of people who have been infected and have positive antibodies is still really, really low in our community. And we're still seeing numbers increasing in our nursing homes and in communities where prisons, nursing homes where people are at highest risk. And we don't have great testing yet. So it's a little bit of flying by the seat of our pants as we open here. And we'll have to see, how it goes in the next couple weeks as we reopen. But certainly we're moving that direction now. And so, Dr. West, tell us a little bit about COVID in Washington, D.C., Virginia area, what you're seeing now in practice, and then we'll switch gears and jump to osteoporosis.
Sure. Well, we are in the Northern Virginia area. We are really in the midst of our surge right now. We're averaging about 200 new cases a day in Fairfax County alone. There have been about 218 deaths just in our county. The hospitals are not at capacity, but they are definitely very busy. And everybody is aware and watching. They've just recently loosened our restrictions a little bit as well. Elective procedures have restarted as of last Friday. And doctors' offices, dentists' offices, et cetera, are reopening. So many of those were still busy anyway, but there was a lot of telehealth being practiced. And, so we'll see how all of it goes. But I have found that after 6 weeks at home, a lot of people are eager to start to get back to a little bit of routine, particularly with their healthcare. So,
and are you starting to see patients again in the office now?
I am, yeah. And what we do is we offer people the option for a telehealth conference or an in-person visit. We haven't quite gone back to full physicals, et cetera, in great detail yet. But we're finding a lot of interest in antibody testing, which we do offer. So
right. Awesome.
It's been very busy.
Right. And a changed universe for both of us, for sure.
Yes, indeed.
So, I mean, I think what's been fun, I think, is, prior to COVID, I hadn't really been doing Facebook Live, and it's actually been an interesting vehicle to communicate with the community and patients. And I think you're finding that too, correct?
Me too. I've started a weekly Zoom call for patients, and it's actually a lovely opportunity to get online and be a little more informal with question and answer sessions, and be able to share good information. So we're all getting used to it.
Well, I don't know if you're
been wonderful. The silver lining, of course, of this whole process is the time that we're getting to spend reconnecting with family and friends, and having kids around the dinner table again, and not rushing off to activities. And it's really, there's some real pluses there. So.
Right. So I don't know if your experience is the same as, you and I do a lot of women's health primary care. It's been a new journey, having the time to really get into a whole nother space again, right? The pandemic, I think, has forced us both to really delve into infectious disease and pandemic, and all of the viral transmission of COVID, and learn how to navigate this, which I think on one level has been fun. I don't know if you are starting to get a little tired of it too. I'm a little bit ready to get back to my women's health space and start talking again about menopause and sexual medicine and cancer survivorship, but and osteoporosis, which is really what I want to talk about today, because I think many people are really tired of COVID at this point, and there's other things that we should start to refocus on again.
We don't want to forget. We want those chronic diseases to be really well managed, so that people are at their best headed into a potential COVID infection.
Right. So, your patients and my patients, and I think women in the community often really focus on breast cancer concerns and worry about breast cancer, and certainly that's really important. Certainly, you and I both know that cardiovascular disease is still the leading cause of death of women, but I think what's under-recognized is the significance, the prevalence, and the impact of osteoporosis on health and longevity of our patients. And I wonder if you could just talk a little bit, tell our listeners a little bit about kind of osteoporosis statistics and what we know, and what people should be concerned about.
Sure. Well, osteoporosis was really recognized as a serious health issue when C. Everett Koop was Surgeon General back 25 years ago. And he made it his mission. That's right. He made it his mission to really make sure that people understood what osteoporosis is, and understood that it is preventable. And so we have been living with that legacy since. I have a wonderful painting called the 3 Ages of Woman by Gustav Klimt, which is hanging on one of my walls in the office here. And it depicts an older woman, a woman of childbearing age, and her young toddler, all women, 3 generations together. And the older woman has the classic postural presentation of a person with osteoporosis. And you see the head bent down, and the difficulty gazing forward, and the curved spine, and the compressed lungs, and the protruding belly. And you realize that when he did that painting 100 years ago, that was considered pretty normal in Europe for women as they aged. And we know now that doesn't have to be the case. So we have been fighting this and trying to raise awareness for a very long time. There are tremendous risks and problems associated with osteoporotic fractures. And we know that 1 in 4 women is dead within a year of a hip fracture. We know that vertebral fractures can cause a lot of pain and disability. And those hip fractures can lead to loss of independence, loss of ability to live in your own home, loss of ambulatory, capability. And that's a real problem. So we have come to understand a little bit better some of the things that we can do to prevent osteoporosis, and then how to look for it. And then once it's been diagnosed, how to treat it. So it's a serious concern, and it should be on everybody's radar screen. And sometimes it just isn't. There are other more immediate pressing concerns that people have. So
right, I certainly know, and you know this too, that despite having an ability to really diagnose it and lots of good treatment options, that in the last several years, the frequency of bone density testing has gone down. And we've actually seen an increase again in osteoporosis related fractures. And there's lots of reasons for that you and I could get into, that's political, I think, driven, and about healthcare financing. But I see we have some great questions from everyone. So I think we should take questions because there's a lot. So can you explain, Dr. West, exactly what osteoporosis is? What does that mean?
Sure. So osteoporosis it's a microarchitectural disruption of the bone. And what happens is that over time, the bone slowly starts to erode. We make new skeletons about every 7 years or so. And the bone is constantly building up and then being broken down and rebuilt to keep it strong and healthy. And what happens over time is that there are a number of different variables that can lead that rebuilding process not to go all the way back to normal. And so osteoporosis is a loss of bone strength, a loss of the density and mass of the bone, which makes people more susceptible to fracture. And the number one cause of osteoporosis is decreased what we call sex steroid hormones. For women, that's estrogen specifically. For men, low testosterone can have the same problem. And it is most often a disease of aging. So, but there are other things that can cause problems for people too. Things like overactive thyroid for a long period of time, certain medications that people take, specifically, the most significantly, long-term chronic steroid use, and other disease processes. We know people with autoimmune disease are more susceptible to osteoporosis. So type 1 diabetes and rheumatoid arthritis are real risk factors. There are problems with diet, not getting enough calcium, having very low vitamin D can be a real problem for people and can lead to slow loss of bone. We can see osteoporosis or loss of bone density in young people too. We see it sometimes in our female athletes who are working out so hard and their diets may not contain all the calcium and vitamin D that they need, and they may actually have interruptions to their menstrual cycles, which can put them at risk for losing bone over time. So,
right,
variables.
And don't forget, smoking is a risk factor.
Smoking is a huge risk factor, and also excessive alcohol intake is a real problem.
Another reason to minimize drinking and smoking.
That's right.
All right, other questions. Are there ways to preserve good bone health? What do you tell your patients?
Yes, there are. And we know that many of the things that we already know about staying healthy, all the same things that our grandmothers taught us, are still true. Getting enough rest, exercising regularly. So for osteoporosis, that is similar to the American Heart Association recommendations, 30 minutes of active, moderate activity or better 4 to 5 times a week. Weight-bearing exercise specifically helps a lot. You have to be careful when you go to a gym, for example, because if you get on a stair stepper or you get on an elliptical machine, those actually are designed to be less weight bearing. And so you don't get the same osteoporosis benefit that you might get if you go out dancing or go for a walk or a jog. So exercise is a key component. Another key component is getting adequate calcium and vitamin D. And it's typically recommended for adult women to get about 1,200 milligrams of calcium daily, 12 to 1,500 as people continue to age, and at least 800 international units of vitamin D daily. And calcium supplements have been a little bit controversial because too much calcium, it turns out, can cause problems for people too. So the best way to get your calcium is through the diet. And dairy products are an obvious source of really good calcium, but there are lots of other places where you get it too. It's in fortified and enriched cereals. It's in English muffins. Calcium is found in it. You can find a calcium fortified orange juice. Even fruits and vegetables have a decent amount of calcium naturally in them. So aiming for enough calcium every single day helps a great deal. Vitamin D is a little harder to get naturally. There are problems with, vitamin D, the kind of vitamin D that helps the bones needs to be peripherally converted in the skin. And that happens when you're exposed to sunshine. But the problem with that is, of course, the risk of skin cancer that has been increasing over time. So trying to find the right balance can be challenging, but you won't have a lot of peripheral conversion into the right form of vitamin D if you are out in the sun all day and wearing sunblock, which of course is the recommendation for skin problems. So, and it's really hard to eat enough sardines to get calcium in the diet. So really recommended that people consider a dietary supplement of vitamin D. And we find vitamin D, vitamin D is a prohormone. It affects 90% of the cells of the body. And so it found, and it has all sorts of different impacts and effects. The cancer teams are very interested in studying what the relationship is between low vitamin D and cancer risk, and many different kinds of cancer. People have found an association with low vitamin D and something called seasonal affective disorder. So getting plenty of vitamin D, especially in the winter months, through supplements can make a difference. Definitely helps with bone preservation.
And when do you have your patients get their first bone density test, and how frequently do you recommend bone density testing?
That's a really good question, and there's been a lot of debate swirling around it. It sort of depends on which recommending organization you go with. We know for sure that every woman 65 and up should have one bone density test in their lifetime. That is not even up for debate. And the National Osteoporosis Foundation would also add that men 70 and over should have one. Getting that paid for through insurance is a little trickier. There are quite a few women who would fall in that 50 to 65 age group who would also benefit from a bone density test. And they might be people who have a strong family history of osteoporosis. One of their parents broke a hip, or people who have some of those risk factors we were talking about earlier, different health conditions, breast cancer on certain medications following the treatment of breast cancer that can lead to lower bone mass. Now, if you have one of those major risk factors, it's reasonable to start getting a bone density test or routine testing starting at age 50. Some people even younger may need them if they have really clear problems, if they've had stress fractures or obvious fragility fractures, even before age 50, it might make sense to check a bone density test for those people as well.
And then how frequently?
That's a really good question. They say that if the one at 65 is completely normal, then chances are you don't need any more bone density tests. If they find low bone mass, which is defined as a measurement on the radiologic screen, we use something called a T-score, which indicates the amount of bone density below a standard, like the median. So a T-score between -1 and -2.5 would warrant watching. And usually for watching with osteopenia, we look at about every 2 years. And then for people with full-blown osteoporosis, it used to be that we checked every year, and now we don't do that. We've learned that there's a difference between, it takes too long for bone density to change, to pick up significant change in the course of 1 year, except in certain very specific medical conditions like hyperparathyroidism. So in general, we go with about every 2 years. And recently, the guidelines have changed to discuss maybe start people on 5 years of a medication treatment and check it after 5 years. Make sure that the treatment is having some impact.
Right. Great. More questions. There's lots. Which comes first, the break or the fall with our older patients?
That's a good one. And I'm not sure anybody has the exact answer. I really can see both sides of the coin. I can see, once your bones have become significantly thinner, then it is possible to take a step in just the right way with just the right weight distribution and have it be enough to break the bone. So
I think the key thing that you said before and that people don't realize, right, is the mortality rate from a hip fracture is 25% at 1 year. And, it really just highlights that this is, kind of, we talk about hypertension as being the silent killer, but really undiagnosed severe osteoporosis is another silent killer. You don't have symptoms with your osteoporosis, and left untreated and having a osteoporosis related fracture has a very, very high mortality. And so this is something I encourage all women, if you're listening, if your physician has not brought up any kind of bone health evaluation or discussion with you, or even discussed calcium and vitamin D supplementation, I really encourage you to raise the question with your physician and make sure you're talking to them about it, because at some point you should have a bone density evaluation. Okay, how common is osteoporosis, Dr. West?
Oh, it's very common. The statistics are as high as 1 in 2 Caucasian women over age 60 or age 65 or 70. Right. Very, very common. And fortunately, we've made a little bit of a dent in reducing the fractures with medication management, just raising awareness. But, there does seem to be a correlation with your risk associated with skin tone. So lighter skin tone people seem to be a greater risk for fracture than darker skin tone. And, it's unclear exactly what role the melanin plays, but may have something to do with vitamin D. Still, lots of unanswered questions.
Right. One of the other things I would just remind everyone too is family history is very important. So if you are a woman and you know that your parents had, your mother had a hip fracture or compression fracture, that's something to raise awareness about you. And then don't forget weight, low body weight and small bone structure, which is me. So I have pretty significant osteoporosis myself already, even though I'm not over 65. So I have lots of risk factors. But again, so these are the kind of things that I encourage all women to do. Talk to your doctor like Dr. West, who knows about this. Make sure you're getting appropriate care and screening. All right. Do I need to take a calcium supplement? What do you tell your patients, Dr. West?
I would say if you have not been diagnosed with osteoporosis, do your absolute best to get calcium through the diet. And you can go online and Google list of calcium rich foods, and you can get a really nice summary. And I actually, one of the food trackers, I don't remember if it's Runkeeper or, all these different apps on your phone that you can log and record dietary intake. Some of them actually track calcium as well. And so there are lots of different ways to get calcium through the diet, and that's preferred. But that said, if you are sensitive to dairy products, or you have, gluten insensitivity or other issues where you're very concerned about absorption of the calcium, then it's okay to go ahead and take a supplement. But most people don't need more than 500, maybe 1,000 a day in addition to whatever they're getting in their diet. I think we went a little overboard on calcium supplements for a while, and it's been ratcheted back over the last few years.
Right. I would tell you personally, I don't get very much calcium in my diet. So I've tried, and I talk to patients about this a lot, all the different calcium supplements myself personally. So the problem with calcium, and I would just remind everyone, is that it's a big molecule. And if you're taking a daily multivitamin in general, they have a very small amount of calcium in them. You really need a separate calcium supplement. The pills for calcium tend to be very large. Mm-hmm. They tend to be chalky. They tend to be hard to swallow. I don't like swallowing the calcium tablets. It's a real disincentive for me. I personally prefer chewable, and there's all kinds of ways to get chewable, either the Viactive chews, or you can, again, use fortified orange juice or other ways to get it, but also chewing Tums can be helpful. Constipation can be a real issue with the supplements, and it also helps with absorption and with the constipation to take it with food with a meal. So again, and splitting calcium supplements, if you need to take 1,000 milligrams a day, which is a lot, and I will tell you most people get really constipated if they do that all at once, is to separate it out. Although again, split dosing makes people very much less compliant. But again, my trick sometimes is to leave Tums in my car and to try to remember to chew a couple when I'm driving, but it's not perfect. I don't know if you have any other tips that you tell patients, Dr. West?
The body really can't absorb more than 500 at a time. So it always makes me wonder, well, maybe the constipation is because your body just can't process it. It's trying to get rid of the excess calcium. But also some people really like taking something that has magnesium in it as well. That can balance out the constipation.
How do you feel about supplementing magnesium and zinc for osteoporosis? So that's the next question. There you go.
Yeah, I mean, there's emerging data that would support that some calcium and zinc supplementation may be helpful. I think we're watching that. So.
I've been diagnosed with osteopenia through a DEXA scan. I take calcium and D2, 50,000 units a day, a week. What else can I do to help slow the process?
Weight-bearing exercise.
I think this individual, who I know quite well, does a tremendous amount of weight-bearing exercise. She's tiny, so that's. And again, I hope that you're minimizing alcohol, not smoking, doing lots of weight-bearing exercise. And at some point, there's something, and Dr. West, you may want to comment about calculating your frax risk, about when you would start prescription medication, or how you decide that for someone like this. So she's not 65, this particular patient. She's got osteopenia. I don't know how significant her osteopenia is, but she's doing what she can with calcium and vitamin D. At what point would you, and we're gonna play a game here. So say that she's 58 years old and her T-score is minus, and I'm making this up for this patient, her T-score is minus 1.8. How do you decide when, as a physician, you discuss prescription medication?
That's great. And fortunately, we have a wonderful tool called FRAX, which is the Fracture Risk Assessment Tool. And it's an online calculator. Anybody can go onto the website and plug in numbers and get a risk calculation. And the variables are a lot of the things we've talked about before, but age, gender, current weight, if you've had a previous fracture, if you have a family member, particularly a parent with a broken hip, that's considered relevant and ups your risk. If you're taking one of the medications that can cause reduction in bone mass, if you have a history of an ongoing medical condition that could lead to low bone mass, and the alcohol intake are the variables that are plugged in. And you can do it with or without a bone density score. You can use the calculator without a bone density score. In fact, that's often recommended in a lot of places in the world where it's not so easy to get a bone density test. And the calculator will crank out a number for you. And if there are two numbers, one is the overall global risk of fracture, and the other one is specifically the risk of a hip fracture. And when those numbers are greater than 20% for the global fracture risk, or greater than 3% for the hip fracture risk, then medication management is indicated.
And there's lots of concerns. How do you talk to patients about the concerns about taking Fosamax or the bisphosphonates, that class of medication? There's all this negative press about osteonecrosis of the jaw and spontaneous femur fractures. And how do you talk to patients who really need treatment about their concerns about these medications?
The bottom line is that these medicines help. They cut your fracture risk in half. And we don't have a whole lot of other treatment options that are readily available that don't cost an arm and a leg that can do that. So, we're all in the osteoporosis world. We wonder whether bisphosphonates are eventually going to be replaced by something better. But we have other options now, but we're not there yet. The bisphosphonate is still the first line of treatment. And what I remind people is that, because they're getting a lot of negative press, they're hearing from their dentist that they shouldn't take this stuff, and they're growing old bones, et cetera, et cetera. But the reality is that you have to weigh the risks. What's worse, being dead and one of the four people who die following a hip fracture, or it taking some chance for a possible mouth infection. The osteonecrosis of the jaw issue really only occurs globally in about 1 in 25,000 patients. And there's been a lot made of it. Some of those patients can be identified. Like, we know people who are going to be at higher risk for osteonecrosis than others, particularly people who are undergoing cancer treatment, particularly people who already have something wrong with their bone regeneration process, or who are immune compromised for some reason. And what I say is try it and see how it goes, and understand that even if one of these side effects develop, we have very good treatments for those side effects. And you just, the bottom line is that once the osteoporosis gets to a certain point, no amount of amazing good health, no amount of lifestyle intervention, no amount of exercise is going to stop you from eventually having enough bone loss to have a fracture. So the medicine is important. I mean, it's a game changer. I mean, if it means that you are on that downhill slide with bone loss, and we can put off a hip fracture from age 75 to age 90, why wouldn't we want to do that? So.
And I think we have time for one more question. Can you suggest an exercise that is good for spine? What do you tell your patients?
Ooh. There are different stretching arm exercises that are really good. There's also, you could talk to, there's a physical therapy program now that's specifically for bone health that you might find your people have it available. But there are stretching exercises. Yoga is really great for static bone strengthening and muscle strengthening of the spine. Holding the whole postural, structural exercises can be really helpful. The whole thing where you stand up against a flat wall and keep shoulders and heels to the ground, back to the wall, and hold that for a period of time.
And I'm a big fan, I will tell you, just of walking. So impact sports as we age is tough on the spine. So if you have osteopenia and you're doing really high impact exercise, that can be associated with developing a compression fracture. And so I don't love impact exercises as we age, or high impact. And walking is great. Actually, there's good data out of Europe, that really, because they walk so much more than we do here, that 2 miles of walking per day really is probably adequate for weight, as a form of weight-bearing exercise, and is good. So again, I think for all of us as we age, it should be a combination of strength training and weight-bearing exercises. And I guess, let's see, we'll take one more. When I had a consultation, I was steered away from Fosamax. Should I reassess? Oh, that's the person who asked the question about the osteopenia. So I think for you, it would depend on what your FRAX score is. Isn't that what you would say, Dr. West? And without more information, we can't really answer that question. But all right, well, those were great questions, and we've gone on. You've been awesome, Dr. West. We're so glad to have you as part of the Ms.Medicine team. And we will have you back to do more on osteoporosis and other women's health things in the future when we finally get through this COVID thing and we can focus back on women's health. So thank you for your time today, and I hope you have a great weekend in DC.
Thank you, Lisa. Thank you for the opportunity. And yes, you too.
Thank you. Have a great day.
Take care.